Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. So welcome back to Professor Tim Uhl, Professor of Physical Therapy at the University of Kentucky. Tim and I have previously spoken in another podcast around the assessment of scapular dysfunction. And so if you'd like to listen more around the assessment of scapular dysfunction before you listen to this podcast, then that might be a good idea. The title for this podcast is, What Do You Do to Address Scapular Dysfunction? And I really wanted to get some gems from Tim so that he could share with a clinical audience. We know in our first topic podcast, we talked around assessment and diagnosis when it's relevant to assess scapular dysfunction and how Tim decides that the scapula is involved in the patient's presentation. Tim, in this podcast, I wanted to talk to you about how you approach scapular dysfunction. I think it's different than how I do that. And so I wanted to learn from you and so we could talk about that and see where the similarities and differences are. Once you've decided then that it's a component of your patient's pain, how do you typically start to address scapular dysfunction?
Gotcha. Yeah, no, it's good to talk to you again. So if I believe scapular dyskinesis is part of their shoulder pain pathology, now all the scapular dyskinesis tests, visually observing it or reposition it, tells me, yes, I see some abnormal movement. Yes, I can maybe make them feel a little better. Now I have to get down to the individual impairments. So with scapular dyskinesis, if I see excessive anterior tilting at rest or with the arms at their side, or as they start to lift, they sort of tilt anteriorly, more often than not 100% of the cases, I'm worried about tightness in the front of the shoulder. So I'm going to look and see if the pectoralis minor, the lats are pulling their shoulder forward into those positions. So I'm going to look to see if if any of those big muscles or the small pectoralis minor could be contributing to this internal rotation, usually anterior tilt and maybe some internal rotation. I often will start my therapy working on stretching those. If they're in a high irritability state, and they really are painful, I might do it for them. It might be passive, and I progress that to try to get them in a resting position. If they're having numbness and tingling, like a thoracic outlet patient, they might not be able to sustain that position for more than 5 or 7 seconds, and they start to have symptoms. I've seen a lot of times we push them way back, really trying to stretch their pec minor. We cause numbness. So you have to balance that to try to stretch and get those moving. A lot of times I'll see anterior tilting as they lift their arm up and bring their arm across their body. So we see a lot of throwing athletes or overhead people, not just athletes, but manual laborers, firefighters, policemen, people working in construction that have tight rotator cuff tissue. So their internal rotators are tight, or their external rotators are tight and are dragging the scapula around. So as you internally rotate your arm and your posterior cuff is tight, your infraspinatus, supraspinatus, those muscles, that will drag your scapula forward and appear to be an anterior tilt because the humerus is moving and it's bringing the scapula together, bringing it forward. So in that case, then I'm going to stabilize the scapula and work on internal rotation and lengthening those muscles. As they tolerate that, as that symptom subsides or they're not as irritated, then if I do see that I want them to work on thoracic extension, cervical spine extension, sometimes they need joint lobes, sometimes they just need exercise and posture reinforcement. I will use manual therapy skills at the neck, at the cervical spine. I will do foam rollers, those kind of things, working on mobility. So before I really start heavy duty motor control, I need to give the patient the motion that they need if there's any postoperative precautions. So I typically start with mobility. And if they're not too irritable, I will teach them the different planes of movement. We used to call it the ABCs of the scapula, basically teaching them to upwardly rotate, downwardly rotate, anteriorly tilt, posteriorly tilt. Now, I'm a small guy. I like to put people on their side. So I do a lot of this in sideline, where gravity is somewhat minimized for some of these motions. And I don't want to overemphasize upper trap. The last thing a lot of these people need is more upper trap activation. So that sort of minimizes that. So one of my pearls is I like to put them in the side. I can hold their shoulder blade. I can move it where I want to move it. And then when I'm ready to bring the arm in, I can put the arm underneath my forearm and then lift that and move that around. So I'm manually moving that. So I start with mobility. Then I introduce motor control, often in a sideline position. At home, they can do it with the arm supported on a ball or on a table. And then we go down the road of strengthening, or I really think of it as more endurance because it's usually higher reps, not heavy weight. In my mind, if I'm strengthening, I'm doing body weight exercises, 3 sets of 10, 3 sets of 12, 3 sets of 8 with a load, holding weights with dumbbells. That's my mind of strengthening. Maybe a little old-fashioned from DeLorme, but that's how I think of strengthening. This is more high reps, more volume, more fatigue, and I really like using time. Now, in America, we bill based on time codes. So for 15 minutes is how we have to bill. So if you exercise somebody for 8 minutes, you can bill them a TheraX. So at 22 minutes, that's still 1 TheraX. But at 23 minutes, that's 2 TheraX. So that's the billing system in the American market for most outpatient orthopedic clinics. So every 15-minute window, so 30 minutes, and it's basically 1.5 to get to 2 at TheraX and so on. So me personally, I usually try to do things for a minute. Now, Margie, we've written a couple of papers where you like torturing people with push-ups for a minute or side hold rotations. So I'm sort of in that same idea. Plus, they don't have to worry about counting. They can work on form, less on reps, and then they get a minute rest or 45 seconds or 30 seconds, depends on that. So I really try to focus them. I might do 3 sets of 1 minute or 45 seconds, but I'm really more emphasizing movement patterns. So motion, motor control, then I go strength or endurance.
Yeah, okay. So I think about strength. This is just an interesting, I think, discussion to have with you, because I think about strength as having all these different components. I think about, developing a baseline endurance that you would have to build some endurance capacity, and then layering up speed, and then layering up sort of reaction time. And I think about them as all components of strength. What do you, well, how do you think? Do you think that is a good way for me to be thinking, or should I change it? Do you know, what are your thoughts?
Well, if it's working, I wouldn't change it.
Well,
if you're having good success, obviously that's perfect. So because I'm an athletic trainer and because I'm a physical therapist, I've worked in both environments. In athletes, we see them every day, 7 days a week, often. So we intermix that by doing different things on different days. As a physical therapist at an outpatient orthopedic clinic, I might see a patient twice a week. So I've got to give them things that they basically are going to do the majority of the time at home on their own. So I've got to sort of keep it relatively straightforward. So I don't usually go after speed and what I would call power until later in the rehabilitation. And so that often in physical therapy, in my experience, is more at the sports end of things. Now, you live in New Zealand. You have different mindsets. You have people that are probably on average way more physically active than the population in Lexington, Kentucky or Central Kentucky. I don't know. But I can tell you for my athletes, more often than not, I'm alternating things on different days. So we would have a strength workout and an endurance workout, and they would be on different days. So if I'm going after strength, I'm usually thinking more about lower repetitions. But in the shoulder, it is typically more of an endurance activity with my athletes, my quarterbacks, my pitchers, and those kind of things. We're talking 150 throws during a typical practice to up to 200 if you count warm-ups and all the other components. Now, pitching in a game, maybe they throw the ball 30 or 40 times at max intensity if they're a reliever. If they're a starter, it's very much more 100, 95, something like that. So I really try to train to the demands of the sport for those athletic people. Most people, they have to do a job for 8 or 10 hours and they're moving their arms and that kind of stuff. They're not lifting super heavy loads. Some people do, right? Manual laborers, but not, at that point, when I'm thinking about strength, they've got to have pretty good control of their scapula to be lifting 30 pounds overhead or shoulder level.
Can you give us then some guidelines, or I know when we put together that paper on the instability, one of the fundamental things I learned from you was around criteria for progression through the different phases. Can you give clinicians some guidelines around how and when you might start different things? Do you have any thresholds that you like patients to move through before you progress?
Yeah, it's usually somewhere in the neighborhood of 45 repetitions, 30 to 45 repetitions without pain, without symptoms. I'm comfortable to add a resistance. So I'm pretty heavy on the endurance side, obviously. Now they can break that up into sets of 15 or into minutes, depending on how fast they're moving along. So I don't usually add weight until somebody can do 30 to 40 repetitions. I make them hold, isometric hold, activates the musculature to a greater extent than a dynamic activity. So they've got to be able to hold that position. So if we are doing a lawnmower or a robbery exercise, which is a kinetic chain, if you use the prone I's, Y's, and T's like a lot of people like to use, I typically will start with, if I'm doing a prone exercise program, I do prone extension. So I know you use a modification where you keep the arms on the table and then work to lifting them up. I have traditionally, I was trained at the Houston Clinic, and the Blackburn exercises is sort of where a lot of the prone I's, Y's, and T's came from. We would let the arm dangle, much like a pendulum exercise, with the arm off the side of the table, and then have them extend their arm into a safe position. And then I've added making sure the scapula drives and sets that motion. So as they go into arm extension, I want them to lead with their scapula, not lead with their hand. So if you lay somebody down prone and you have them lift their arm, 90% of them are going to anteriorly tilt their scapula. I don't let them do that. So they have to retract the scapula and extend the arm and sustain that position for 3 seconds before they come down. So 30 times 3 seconds or 45 becomes a long repetition of exercises. I don't know what that is off the top of my head, but somewhere in the neighborhood of 900 seconds, 90, no, 3 times. Yeah, 90 seconds, 2 minutes, right?
Yeah.
So that's a sustained activity to being able to do that. And they fatigue
Yeah.
very quick. So why I do that is because of the isometric component that increases the demand time under tension. So now a bicep curl, I don't need to hold that because there's no load. The load is out at 90 degrees. But with a lot of the shoulder and scapula positions, if they're done prone or if they're done inside line or if they're done supine, I use my gravity holds when they're working against gravity as I introduce that. So that's one thing that I think I do a little different than what you and I have talked about in the past, where I make them do a sustained hold and progress them that way before I add any load or anything like that.
Yeah.
Maybe you do the same.
Oh, I was just thinking about the similarities of that, because if you because I like to think about, that posterior tilt and prone, and I've just been leaving them in that position with their hands down to get more posterior tilt. But you are effectively doing the same thing, because you just posteriorly tilt them and then lift their arm to add. So I guess what I was looking for is, because what I've been doing works and what you do works, and I'm interested in the similarities as to that might help explain that.
I think it's getting the scapula back, whether they start with their arm at their side by their hip and you have them lift away from their leg and I put them in a dangle position. We just always started exercises that way, and sometimes they couldn't go through a full range of motion. I don't think it's wrong either way. I think people can do it a lot of different variations. What I do worry about is people go to T's and Y's too fast. And I think your progression, my progression is very much the same. Gradually work them out into more and more abduction as they get good control. Now you do some kind of little movement pattern. I do it a little less dynamically with shorter, long lever arms. I think where people get into a lot of trouble is they see prone T's and they do it all kinds of variations. It's supposed to be done with the thumb up. It should be done with the scapula, and it should be done not with 5 pounds holding a dumbbell. That's a lot, or 2 kilograms. That's a lot of load on a shoulder that's relatively weak and not functional. But somebody will say, well, that's only 1 kilogram. I'm like, yeah. But if you do the math, and I did this at a presentation, if you take the mass of your body weight, your arm weighs 5% of that. If you're a big person, it's probably 5%. If you're smaller, maybe it's 4%. When you add a 1 pound weight, a 2 pound weight, a 3 pound weight, the EMG doing just a good old fashioned scapular plane abduction exercise, it hardly changes.
Yeah.
The weight of your arm is a lot for somebody that's hurting.
Yeah.
And
Okay.
so don't appreciate the external load. Now, you get up to 5 pounds, 2.5 kilograms, or 4 kilograms, right? 8 or 10 pounds. Now you'll see dramatic changes. But giving somebody a 0.5 kilogram of load really doesn't change that much. In the patient's mind, oh, now I'm weightlifting, but it's the pink weight or whatever. But that's plenty, because the weight of their arm is plenty. And I think we don't always think about the internal lever arm of the weight of our arm versus applying any kind of external load.
Okay. Do you think so? I guess I've been targeting, middle lower trapezius separately, then targeting serratus anterior, and thinking about the combination of those muscles working. We'll get to upper trapezius in a minute, but I think about I'm trying to improve the function of those muscles, and I target different exercises to do that. Do you? What are your thoughts around that? Do you think, because he's prone?
Yeah, prone definitely biases the posterior musculature. It's not going to get as much serratus activity unless they're doing push-ups in prone. That a push-up plus is sort of the golden standard of a serratus anterior activity, which is a great exercise. It's closed chain. Not everybody functions there. It certainly can build your strength up, but it's not as functional as what people need. To me, function is being able to reach, pull something down, lower something controlled. And so what I see a lot of times is the scapula wings because the serratus isn't working as somebody brings their arm down. So when a long lever arm, so if I have my arms fully extended and I'm down around 90 to 60, a lot of people will see a lot of posterior tilt, or I'm sorry, a lot of anterior tilting or winging of that inferior angle. And so as you lower your arms, the body is relatively smart and it's saying, okay, the upper traps are going to work and they're going to decelerate. But if they're having pain or discomfort with that, the serratus needs to be facilitated to minimize that winging. So we do a lot of punch, a lot of serratus punch, a lot of reaching up. That's great. That's not how it's dysfunctional. It's dysfunctional eccentrically in lowering.
Yeah. Yeah.
So how do I do that? So what I do is I'll take the TheraBand, put it behind my back, punch out and reach excessively. I do my punch as I'm coming down to activate the serratus eccentrically as they're having to reach. So they're not just lowering their arms, they're activating their serratus. So I tell them, lift your arms out, up and down in the scapular plane or in frontal plane. Now reach as far out as you can. And so the band provides a little resistance. They feel the tension. And so they facilitate the serratus in a more functional pattern of lifting and lowering. If you put the band straight.
Yeah, sorry. No, you were going to say if you put the band straight down?
If you put the band, under your foot, you're still going to load your rotator cuff and deltoid.
Yeah.
So I like putting the band around the person so they're having to reach across, or I'll hold the band behind them.
Yeah.
I can use a dumbbell stack. It's a matter of sort of facilitating that. So when they're lowering, they're having to work against that resistance. The band gives you a little bit more flexibility than a dumbbell stack, but you have to change the angle of that band. It can't just be in one position as they go up and down.
And maybe that's where I've run into trouble, because what I've seen when I've tried to do those kind of punches is that people tip then and use what I perceive to be more upper trapezius than serratus, and perhaps because I haven't changed the angle of the band, but I've really steered away from that as an exercise because of that patterning that I see.
The other trick is to supinate.
Okay.
So if they're internally, if I punch you, right?
Yes.
So you're on a video, I won't punch you, but I'm internally rotated. I've got my fists like I'm actually punching a punching bag.
Yes.
If you externally rotate or supinate, now you've done a couple of things. You've tightened up the capsule.
Yeah.
You've activated biceps, which also is a supinator. So you're getting a little bit more shoulder stability. And if you palpate the serratus and you resist supination, like a Jurgensen's test, you'll feel activation of your serratus. So instead of keeping their band pronated, put them in neutral or supinate them. And as you resist supination, you'll feel, now some of that might be lats because it's getting stretched, right? External rotation is going to stretch the lat. But if you can palpate the difference between the lats and the serratus, you can actually start to feel activation up underneath your fingers and palpating that serratus just by turning their wrist, or not just the wrist, but their whole arm.
Supinating
now I'm punching this way. It feels very weird. Nobody punches like
that way.
But Ekstrom showed a long time ago with EMG that the uppercut really turns on the serratus. And that's where I got the idea from, is externally rotating and uppercutting, which turns on the serratus. I'm like, well, who said we have to lift our arms like this? We can lift our arms like this.
I think what I learned.
Sorry, that's on a podcast. Let me say, with the palms up is much better.
Yeah.
to
What I learned
facilitate.
from you when we did that EMG study, you know, that when we did the Baber, looking at patients pushing a ball, here we are both using our hands. So people can watch this on the video. But
Oh,
we're
okay,
both
that's
pushing
good.
our arms up into like an overhead press. That serratus anterior is really, really active in that overhead press. And so if I don't, because I also think then about substitution to latissimus dorsi and whether people use different muscles instead of that. And I want to talk about substitution in a minute. But what I've been doing is then as a isometric hold here is to increase the weight overhead as an isometric carry, I call them. And then before I progress them into then an overhead press. And so I've been doing that in a similar way. I think my question for you then takes me into the substitution patterns, because I pay attention to what muscle are you using? I haven't been using the push-up plus, because typically I see in that position they drop into that anteriorly tilted position, and in perhaps a cuff patient that isn't necessarily the position I wanted to train them, and so I would train their serratus anterior in a different way. My question is around upper trapezius. Let's start there. When should we strengthen? When should we alter our exercises so there's minimal upper trapezius? What are your thoughts around the patterning and strengthening and treatment of that?
Well, it certainly gets a lot of playtime. People worry about that a lot. Paula Ludwig has done some really nice research looking at EMG and came up with this upper trap, lower trap, or upper trap serratus ratio, and basically showed that if you do a push-up plus, you get a better serratus activation without overactivating the upper trap. And Cools did sort of the same thing with some of those prone exercises, showing that prone horizontal abduction and some shoulder extension was facilitating the other scapular muscles and not overactivating the upper trap. In complaints of patients, they say, I hurt in my upper trap in my levator, and the assumption is that it is overused, and we're seeing a substitution pattern. They might be weak.
Yeah.
They might have a substitution pattern that is functional, like a reverse total shoulder. So a reverse total shoulder has no rotator cuff, theoretically. That's changing in current practice. And they need to lift their arm by shrugging their shoulder. And their shoulder hurts because they have arthritis. But maybe the soreness is because the trap wasn't strong enough in the first place.
Yeah.
I think there's an assumption that we need to balance that. That might be true. I don't know that we know with assuredness that I can stand up in front of the world and say,
this podcast
shouldn't strengthen. And yet, Dr. Olds and her
stand up in front of me, Tim, and all
say,
our listeners. Yeah.
And
so
say,
how do we
and say the upper trap shouldn't be strengthened.
Yeah.
I'm strengthening everything to a degree. I can't shut off the upper trap, right?
No, but we can preferentially load.
We can, and that seems to work most of the time, but it's not like we have said, okay, we're not going to strengthen it at all, which is almost impossible. And can I get rid of their symptoms? Like, to my knowledge, nobody's ever done a program where they've included shrugs and all of the other exercises to fix and said, oh, that works better because I got the upper trap stronger than avoiding the upper traps, or minimizing, I should say, or biasing. I've thought for years that we shouldn't, but I'm not 100% convinced that the upper trap still isn't very important. Watching reverse total shoulders, right? So when I started in clinical practice, there was no reverse. When I was down at the Houston Clinic in Columbus, Georgia, we only did anatomical total shoulders. And there wasn't a patient that I rehabbed, and I rehabbed a bunch of total shoulders that didn't have some substitution patterns. We tried to minimize that, but people have to live their life, right? And their rotator cuff might not be as good as it once was. And so if I need to reach the second or third shelf, and my shoulder pain is way better, and I shrug a little, is it the end of the world? Maybe not. Right? So I'm short. I'm always shrugging, right? So I'm always using stuff overhead and that kind of things because I have to reach to get to waist level, right? But I think I don't know in the heart of hearts that I always want to substitute and not use the upper traps. I do think biasing the serratus and lower traps that are weaker is helpful. So I think that's logical.
Yeah.
But I don't know with certainty that you're totally shutting down the upper trap or avoiding its utilization. Maybe you just strengthen it so it's not so sore, right?
Yeah. And maybe as a byproduct of your other exercises, that's what you've ended up doing.
Right. But there is a lot of emphasis because that's an easy substitution pattern. People see people shrug when they don't have a rotator cuff. After a reverse, we're starting a research project on looking at pre and post scapular kinematics for reverses. So we're getting ready to write an IRB. That's one of my doctoral students, one of his many projects. And so we're interested to see how that changes. Nothing's ever going to be perfect. When we get into scapular kinematics, we've talked all about clinical stuff.
Yeah.
We're probably not going to see perfect scapular kinematics after surgery, right?
No.
I don't know. We'll see. It's probably better, but it's probably not going to be perfect. So my sense is without a rotator cuff, I'm going to see a lot of upward rotation, and maybe I'll see a little less upward rotation when I have the reverse in. But my question is, will it totally go away? I don't think so. I think we're going to see some substitution. There is some work that strengthening those muscles may suggest that you're less likely to have a spine fracture, a scapular spine fracture, by getting the scapular muscles stronger prior to surgery. Now, that was presented at a conference I went to locally, and they had this external expert. So I haven't seen this paper, but he was referring to another presentation he had seen where people are starting to look at preoperative scapular exercises to get the shoulder muscles ready to handle the increased load of a reverse prosthesis. So we'll see if that
just with regards to increasing bone health and bone density from the wow, isn't that interesting?
So I think would I still try to bias the serratus and lower trap? Absolutely.
Okay.
Absolutely.
I'll stay with that plan for now then.
But would I say that I've not going to ever strengthen the upper trap? I can't say that with complete confidence yet because it's too active all the time.
Yeah, and I think maybe there's more work needs to be done in this space, or maybe there's individual variations.
Yeah, I think there is definitely some work. People always ask me, and you haven't asked me this question, so I'll throw it out myself. Do you focus on the cuff first, or you focus on the scapula first? I really don't think you can focus completely on one or the other, because when you elevate your arm, in a normal human being, their scapula and rotator cuff have to work together. And so if you don't treat this as a system, you're probably missing the boat. Can I bias one muscle over another for a period of time, I can. But if I'm going to work in function and within the inter-regional dependence model or the kinetic chain model, I've got to be able to coordinate scapula, humeral, spine motion together. So I can be functional and do it over and over and over again to do my sport or to do my daily activities with as good a motor control and as good a mobility and strength that I can have. People overtrain in athletics to the point of injury. People undertrain, not in athletics sometimes. And so there's a sweet spot, right?
Yeah.
So our job, typically what I tell my athletic training students is we've got to pull the athletes back a little from their overtraining modes. And we got to motivate the people less physically active to get them all back into that position of moderation, right? And so the volume of work that we're doing in daily activities probably isn't really completely appreciated. We all have little step counters on our watch now. That tells us a lot about walking. Doesn't tell us anything about how much our arms are being used.
Yeah.
And so different jobs, different demands. People are starting to look at this more and more with pitch counts in workloads and that kind of stuff in baseball, rugby, your world, right? Rugby, a lot of great research out of New Zealand and Australia and those areas looking at practice and overload injuries from muscle strains. I think there's a lot of room for that for arm motions, arm activities. My hometown, Georgetown, is the North American largest motor manufacturing of Toyotas. So we get a ton of upper extremity overuse injuries, and it's been around for 30 years. So everybody's aging. So they're all getting rotator cuff, tennis. Yeah. So this central Kentucky area is seeing a lot of retirees with a lot of increase in reverses and total shoulders, and those kind of population, just because it's been around for 30 to 35 years, whatever it's been. And so the volume might be a factor too.
Yeah. Tim, look, it's been absolutely sensational, as I knew it would be. I've really appreciated you sharing your gems with us. Do you have any closing remarks for clinicians around treatment of the scapula? Is there anything that you think, we talked briefly before we started, didn't we, about trying to give some more depth to some of the clickbait that is around? Is there anything else you really want clinicians to know with regards to scapular treatment or how to address this dysfunction?
I think the closing remarks would be when you think the scapula is involved, figure out what's causing it not to work right. Is it a mobility? Is it a motor control? Is it a weakness, a true neurological weakness, right? So that compensation of classically a tight pec, tight lats, you've got to address those as you start to introduce your interventions. You can't just go to strengthening right away. So you've got to treat the mobility limitation, teach them how to move their scapula correctly, educate people to feel their movements. I think physical therapists, athletic trainers appreciate movement because they study it all the time, and they don't realize that the rest of the world doesn't really think about it. If you ask a highly skilled athlete, how do you hit that ball so far? Or how do you throw? They really don't know. They just are gifted and they can do that. So we have to really break that down. So as you start working on a patient, you really have to figure out, is it tightness? Is it motor control? And address that issue. Then integrate that into how they move and what's important to them. Some patients, it's being able to do a sport or an activity. A lot of patients in the general population that's just doing their job, driving. What can I do to offload or support that arm while they're recovering. And I think a lot of people go long lever arm way too early. Keeping things close to your body, getting things in good motor control and position before you move is critical to get them ready to start doing functional activities.
Yeah, I think that's fabulous advice. I agree. Sometimes I see patients that come in with these, the therapists have given them these long lever arm, and the short lever arm just really helps them to move in a different way, doesn't it?
Yep.
Tim, thanks again for your time. It's been absolutely wonderful, and I knew I was going to learn a lot from you, so I've really appreciated it. Thanks again.
You're welcome. I've learned a lot from you, so it's mutual.
Cheers. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.